Hi, everyone. I'm Dr. Bruce Struminger at the University of New Mexico School of Medicine. I'm an associate professor in the Department of Internal Medicine in the Infectious Disease Division, and also an associate director at Project ECHO. And it's my pleasure to welcome you as the first welcomer and to run through a few housekeeping items before we formally begin. So I'm going to share my screen. Hopefully you're all able to see this slide. So we're building a community of practice focused here on One Health, and today we're going to be talking about the global coronavirus pandemic. And to help us get to know each other, even though we've got over 175 people signed in already, we really want to encourage you to turn on your camera if the bandwidth of your internet permits it, so we can see you and you can see us and we can start getting to know each other. The other item, I'd love to request that you keep your microphone muted during the session if you're not speaking. And also if you can rename yourself with your name and your organization so that we know what organization you're with. And if you move your cursor over your Hollywood square up to the top right, you'll see 3 little dots. If you click on that, you'll be able to rename yourself and add your organization if you don't have it. Please chat Echo IT if you're having any Zoom IT problems, but please reserve the chat function on Zoom for questions and comments. Please refrain from noting your attendance in the chat. We're hoping you're going to use the PDA participant app that hopefully you've downloaded through the link in the announcement. And you can now scan the QR code, which is a start code for this session. If you haven't downloaded the app, you can go to the announcement and click on the link and download the app to your mobile device. And we will make this QR code available a few times through the session, through a link in the session. We'll then also have an end QR code at the end of the session, and we need you to scan out as well as having scanned in so we can attest your participation in the entire session. The presentation slides will be shared instantly with anyone using the PDA participant app. They'll automatically be available on your mobile device, and you'll be able to share them with anyone you want. So hopefully that's an incentive to download that app. We'll also send the slides through an email to everyone who registered for this session. So if you registered, you will get copies of the slides. The session is being recorded and your attendance is consent to be recorded. There's also going to be a link in the chat to the COVID-19 One Health Update social media guide. So for those of you who might be tweeting or posting on Facebook or some other social media platform, Instagram, whatever, there's a really wonderful guide that the team at UC Davis put together, and you can access it through the link in the chat. There will be continuing professional development credits available from the University of New Mexico, CME, nursing credits, pharmacy credits, via a link in the chat at the end of the session. So with that, I'm going to stop sharing my screen and pass the microphone to my colleague, Dr. Jonna Mazet at the University of California, Davis. Jonna.
Thank you, Bruce, and a huge thank you to Dr. Struminger and his whole ECHO team at University of New Mexico. We're so fortunate to be able to offer this session and have them ramp up for us and organize some of our amazing colleagues to really give the rich content today. As Bruce said, my name is Jonna Mazet. I'm a professor of epidemiology and disease ecology at the University of California, Davis and the University of California, San Francisco, in both the vet school and the medical schools. So I'm thrilled to be here today as as I co-lead the One Health Workforce Next Generation project that is supported and made possible through the U.S. Agency for International Development. And you'll meet my co-partner in crime, Professor Valtrina Smith, in just a few minutes. We are just very challenged as a global community by this terrible COVID situation that you're all dealing with, we're all dealing with. And I think by coming together in this kind of community of practice, but bringing together our disciplines and also then making ourselves available through our academic linkages and with our connections and networking through our ministries, I think we can really be stronger together. And I'm thrilled to be part of this network and to be with you today. And we'll have a chance to speak even more about COVID and the associated issues as we go through. So with that, I would like to hand it over to our real host today, the Southeast Asia One Health University Network, and my colleague, Dr. Vipat Kuruchittham. And Pat, if you would like to take it away.
Hey, good morning, everyone. This is Pat. I hope you can hear me. I'm gonna turn off my microphone after this. I turn off the video after this because of the bandwidth. So it's UC Davis, University in Mexico and its consortium. So my name is Vipat of the Southeast Asia One Health.
Pat, we're losing you, and
network, or we call
Pat,
ourselves SEAOHUN.
Yeah.
All right. Can you still hear me?
It's better now.
If not, we can skip. Is it my voice is okay?
Pat, we hear you well. Yes.
That's great.
Oh, all right. So we'd like to just take a brief because we have a packed session today. So I'd like to take a brief introductions to our organization in case you're not familiar with us. So yeah, established in late 2011 with support from the USAID. SEAOHUN is the largest regional network of universities in Southeast Asia, working together to build a sustainable and competent One Health workforce to effectively prevent, detect, and respond to infectious disease threats, such as the global discussing today. So our members comprise subject matter experts of multiple disciplines of One Health in 81 universities in 7 Southeast Asia countries, namely Cambodia, Indonesia, Laos, Malaysia, Philippines, Thailand, and Vietnam. So in the One Health Workforce Next. So we'd like to warmly welcome all of you to the special One Health sessions on COVID-19. So I'd like to pass the microphone back to Bruce, I think. Thank you.
Great. Thanks so much, Pat, and welcome to everybody from myself as well. My name is Valtrina Smith. I'm also at UC Davis, and I'm honored to be the technical director for the One Health Workforce Next Generation project. So what we're going to do, we have an hour and a half all together. We have over 250 participants at the moment. We had over 400 in our AFROHUN similar session this morning for the Africa region. So I'm really happy to see people so enthusiastic to really work together in a One Health approach and to seek information and connection in this way. The plan for the session is that we will have 4 brief presentations, about 5 minutes each or so, from some of our global experts from CDC and others. We will then be able to do some question and answer. So we would ask that you type in your questions to the chat box on Zoom along the way. People have submitted questions in advance as well. So we will take a little bit of question time after those first 4 initial presentations. And then we will go for some regional comments for the local context. And then we will have set time again for Q&A. So that will be the general plan. The topics that we'll touch on initially with our 5-minute presentations are on global epidemiology, laboratory diagnostics overview, infection prevention and control, and the One Health Perspective. So I would like to go ahead and get started. We'll have Manesh Shah giving the first presentation, and please do feel free to type in the chat box for all of you. As you have questions and comments along the way, we will be tracking that and able to follow up later with additional information. Manesh, are you with us?
I'm here. Thank you so much. I hope you can hear me. I'm going to share my screen. I want to thank everyone for having us here from CDC. My colleagues Chris Shio and Katie Wilson will be speaking after me, and I'll start with an introduction on the global epidemiology. And I think the presentation is loading. Are you? Yeah, okay.
Manesh, we can see your screen with the overall slides. We just don't see you in presentation mode quite yet.
Okay. It's showing up on mine, so yeah. Should I begin?
Yeah, go ahead.
Okay, great. So I'll begin with the global epidemiology, starting with on March 11th, about 12 days ago, the World Health Organization declared COVID-19 officially a pandemic. And what that means is that a pandemic happens when a disease emerges to infect people easily and spreads from person to person in an efficient and sustained way globally. This is the first pandemic known to be caused by the emergence of a new coronavirus. And importantly, different countries can be in different phases of the pandemic at any point in time. And within a country, different parts of the same country can also be in different phases of the pandemic. And that is definitely something we're seeing now. The duration and severity of a pandemic can vary depending on the characteristics of the virus and the public health response. COVID-19 is caused by SARS-CoV-2, which is from the family of human coronaviruses. And you'll hear more about these from some of the other speakers. But SARS-CoV-2 has higher pathogenicity than other common human coronaviruses, similar to SARS-CoV and MERS-CoV.
Hey, Manesh, let me pause you there for just a moment. So we can see your first slide and then your first view on the side. It looks like maybe you're not in presentation mode. Do you want to maybe try that one more time for the screen share?
You know what I might have to do?
We can hear you fine. It's just not advancing slides if that's what you want.
Ah, okay. Let me try that one more time. I see presentation mode for me. Are you not seeing it for you?
Well, go ahead and do your screen share again. We've gone back to your main video. Okay, we've got your screen share. Now you need to go into presentation mode, perhaps. It worked fine this morning.
Yeah, how's that?
We can see your screen, but we see one main slide with the bar chart on COVID emergence, and then we see your tracked slides on the left. So for us, it's not screen share for presentation mode. Yep, there you are. You're set.
3 screens going. I apologize for that. Regarding the, and I'll stick right where we are, the emergence of COVID-19, early cases were linked to Wuhan, China, and to a specific Huanan seafood wholesale market. And one of the things you see on this graph, and that's the yellow and green bars here, is that initially the vast majority of cases were linked to the market, but quickly within a matter of days, more cases that were reported were not linked to the market, showing evidence of person-to-person transmission. And after what this visualization shows is the continuation of the transmission, rapid and widespread to all global regions. And we had a little bit of trouble this morning, but I tried it again, it should work. And you can see here, just over time, how COVID has been spreading. And again, we're having trouble. I put in a backup slide. This speeds us up to the current situation. This is from the World Health Organization's situation rep from today, March 23rd. And one of the things you see here is that now the newly reported cases of higher emergence in Europe and in North America, including the United States, but really spreading to all regions. And what I was hoping to show you in the time-lapse videos, the common occurrence we've seen is that in countries with sporadic, a handful of cases initially linked to importation, they've quickly developed into community transmission within days to weeks. And that's been a pretty common feature across countries. Signs and symptoms of COVID-19, no particular set of signs or symptoms can reliably discriminate COVID-19 from other respiratory viral illnesses such as influenza. There's a subacute to an acute onset, non-cough, fever, although often not initially measurable and sometimes never throughout the course of the illness, and then some reports of isolated diarrhea alone preceding the cough and fever. A median incubation period estimated to be 4 to 6 days with a range of 2 to 14 days. And most people will recover spontaneously with supportive care. However, when complications emerge, they include pneumonia, respiratory failure, multi-organ system failure, leading to death. This is pulled from a report of the first 45,000 or so confirmed cases from China, showing age distribution of cases. And on the next slide, case fatality rate, and I'll pull that up here. And one of the things you see here, and this has been shown, the same pattern has been shown in reports from Italy and the United States. As you get older, the case fatality rate increases over time. I'll caution you on looking at the absolute numbers because case fatality rates are difficult to calculate during an epidemic. And when we look back at it, the actual rates may be lower as we find the full denominator of cases. But this pattern driven by age has been replicated in other situations as well. The illness severity, also from the same analysis, 80% of cases are mild, 13% or 14% were severe, and 5% were critical. And this is, again, from China. And I should say a couple of things, that this is part of what's made COVID-19 difficult, is that the mild cases are often to the point of being pre-symptomatic or asymptomatic, and there may be transmission in those states even before fever emerges. So transmission is happening often from mildly ill patients. However, the critical portion does lead to severe outcomes, including needing intensive care and death. So that dilemma makes that the problem of both having mild and critical symptoms is what makes COVID so dangerous. Regarding transmission, the main mode of transmission is through respiratory secretions. Infection is spread through respiratory droplets in the air, and that can land on surfaces. Transmission from persons who are pre-symptomatic or may have been asymptomatic is possible, but the contribution of these infections to overall numbers of illnesses, here it says appears to be small. I would say is unknown at this time with some of the emerging literature. Importantly, in the third point, no transmission yet observed perinatally, which is reassuring. High-risk groups that have been identified are comorbidity and advanced age, increasing the risk of severe illness and death, and that includes cardiovascular disease, diabetes, respiratory disease. Also being immunocompromised, although there isn't data, if we look at other viral illnesses for people with HIV and other immunocompromising conditions, they are at higher risk. Pregnancy, current observational data only exists for women infected in the 3rd trimester, and in that group, maternal morbidity has been similar to that of uninfected women. Finally, I'll end with a couple of items from CDC resources. These are prevention messages available at the CDC website, focusing on what individuals can do to protect themselves, as we know that community communications with the public are a really important part of controlling transmission. And ultimately, a framework to think about preparedness and response framework for pandemics. And compared to the earlier group I spoke with, I think this group has had more experience and may have countries in various stages of the pandemic and may have gone through this cycle of beginning with containment And then as containment efforts become more overwhelming, transmission outpaces those containment efforts and moving to mitigation. So I think this is a great audience to talk about some of your own experiences with this response. That's my last slide, and Chris Shield will do laboratory.
Great. Thanks so much, Manesh. That was a great start to just give us a feel for the context and the current thinking here. So we will go straight over to Chris for the laboratory diagnostics overview, if you're ready. And then for folks who are participating, please do feel free to use the chat box to ask additional questions or make comments along the way. Thanks, everybody.
Hi, everyone. I'm going to be talking about laboratory diagnosis of COVID-19. I'll talk about what you need to do to prepare to work with SARS-CoV-2 in the laboratory, biosafety, risk assessment, and so on. I'll also be discussing some of the coronavirus features that are relevant to the current molecular tests. And then I'll briefly go over the CDC real-time RT-PCR. Before you begin working with SARS-CoV-2, you should perform a biological risk assessment. A risk assessment allows you to mitigate any risks with the work associated with the work. The first step would be to identify hazards associated with the procedures you're going to be doing, with the biological agent, the training of the personnel, and some facility hazards. You identify those things that could potentially increase the likelihood of having a laboratory incident. And then you weigh the likelihood of an incident against the consequences of exposure. And I have a table here on the lower left. If you have a low likelihood and low consequence, you may not need to add additional controls to mitigate risk. But if you have, if you fall in this yellow or red area, high likelihood, high risk, you would want to add in some biological safety controls, such as additional PPE, or you working in a biosafety cabinet, engineering controls, administrative controls like SOPs, things like that, to mitigate your risk and bring it down into this safer area. During the life cycle of the specimen, you want to make sure that you are following best biosafety practices. And this includes transport from the clinic to the lab, also shipping. You need to, it is a regulated organism, and even for unknowns that perhaps may contain the virus, you need to ship these category B, which requires triple packaging. I have a figure up here. And by the way, all the links to this information are on the WHO website, and I've included these on the slides. But not only when you open up the package, let's say, and that's called accessioning, and check your specimens, all this should be done inside the hood, not just manipulation where you're actually working with the sample and perhaps vortexing it, creating an aerosol. This biosafety cabinet creates a wall of air that protects you from any aerosolization of the virus. Also, the waste is category B, and that is simply its general biological hazardous waste. You dispose of it in the appropriate container, and it requires autoclaving or incineration before it is taken to the dump site. So definitely prepare if you're going to work with SARS-CoV-2. Okay, I'm going to discuss some of the coronavirus features. You've probably seen this figure many times with the little spikes on it. These are relevant to the different assays because you'll probably see some of these protein names included in any molecular assay that you might be using. It's an enveloped positive sense single-stranded RNA virus. it can hijack your DNA to make its own proteins. The various proteins that are particularly relevant, although it has many more, are the nucleocapsid, which binds the internal genomic RNA together, and it's inside the envelope because it is an envelope virus, and that is shown here on the upper right. There are some membrane proteins that transect that envelope, and then the spike proteins, they're shown in red here, and those allow the virus to do is attach to the host cells. And so there's a lot of research ongoing into these spike proteins to see if they can somehow be disrupted genetically to reconfigure the protein so they do not attach. I'm sure this should be very interesting moving forward. So the genetic sequence, I think Manesh probably mentioned this, is very similar to the SARS of 2003, and even more similar to bat coronaviruses that have been found. And laboratory tests that have been posted for actually quite some time, because the genomic sequences were available, are on the WHO website. These have been there since the end of January. I think just recently, another test, a Pasteur test, was added, but all the protocols are available, including the CDC test. But all of these tests detect virus. There are no tests included there that detect humoral response for convalescent phases. That will come later. I want to kind of go away from this slide for a minute because the landscape has changed quite a lot since I even prepared these slides. The US FDA has gotten emergency use authorization for several tests over the past week. So it's very exciting news because CDC can recommend tests that are approved by the FDA. And so there are not only manual tests similar to the CDC, real-time reverse transcriptase PCR, but there are some more high throughput tests and also near point of care tests that you do very little manipulation, and many doctors' offices or hospitals could actually run these tests. I'm talking specifically about the Cepheid Gene Expert Express SARS-CoV test. That is probably the closest thing to point of care that we have approved so far. And that test, it looks like you need to get the new machine, which I had mistaken reading the protocol, but it works on any Gene Expert machine. And this is great because there are Gene Experts placed all over the world. They've been used for TB, for flu, for Ebola, for many different diseases. There's several assays that people run on these machines. So this is very exciting news. There's also another high throughput test. It's called the Roche, well, it runs on the Cobus 6800, 8800, which is another very automated machine. The DNA extraction occurs. You don't do anything manually, but it's very, very high throughput. And labs that are doing HIV viral load testing, several of those labs may have this instrument. And so that is very good news. The point, I just do want to point out that the antibody detection test.
Unmute speaker.
Hello? The antibody detection tests are not recommended at this time by either WHO or CDC. None of them have been thoroughly evaluated. And I'm going to go to the next slide. This is basically a very short description of how the manual real-time RT-PCR works. Your human specimens, either NP or OP, are preferred. You extract the RNA. Then you use your primers and probes, which contain fluorophores. You set up your test using and add in your RNA, appropriate RNA. And then you set up your plate. But interestingly, if you haven't seen this machine, it's called real time because you can visualize the fluorescence as it's released when the amplification occurs. So this machine not only cycles and performs the PCR, but also detects fluorescence. And I really made that short, but there you go. Thank you very much. Moving on.
Fantastic job. Thank you so much.
All right, you're welcome.
Coming in on the chat box, so we'll get those compiled and be able to circle back to a few of those today. And we are going to go on with our next overview presentation. We'll pass off to Katie Wilson to talk a little bit about infection prevention and control. So Chris, go ahead and stop your screen share and have Katie come on.
Sorry about that.
Nope, sounds great. And then it just says the general practice for those on the Echo session on the Zoom here, go ahead and mute your microphone if you're not talking, just to avoid background noise as we go along. Okay, welcome Katie, and we can see your screen share, and then you'll just need to go to presentation mode, and it looks like you're good.
Hi everyone, I'm Katie Wilson. I'm from the Division of Healthcare Quality Promotion at CDC, and I'm an epidemiologist that specializes in infection prevention and control, or IPC. We're going to very quickly just go over some highlights and messages and reminders about IPC during this COVID-19 outbreak. So IPC, as we all I think know, is the science of preventing or stopping the spread of infections in healthcare delivery. So healthcare can happen in many settings: hospitals, outpatient clinics, dialysis centers, long-term care facilities, traditional medicine, and many other locations. And so we call that the spectrum of healthcare delivery. And the main goal at this time during an outbreak for infection control is to support the maintenance or the functioning of healthcare services by containing and preventing COVID-19 transmission within healthcare facilities.
Hey Katie, let's pause for just a moment. You're having the same challenge that Manesh had, where we can see your slides, but we can see one main one, and then we can see your row of them on the left. So maybe try the presentation mode one more time, because it worked fine this morning.
I think if you click swap screens, you'll be great.
Okay.
The audio is great for me. So if folks are having trouble with the audio, I think that's related to their individual bandwidth. But Katie, you sound fine. So when you're ready, try again. I can see.
Let me try sharing one more time.
Yeah, great.
Sorry, everybody, loading into presentation mode. Let me just swap here. Apologize, it looks like it's showing up on my other screen. All right. Did that work this time?
I think that presenter mode closer.
This can work, Katie. We can see your one main slide, and then we can see the next one that's coming, which is not a problem if that's what works for you right now.
Okay. Okay, there we go. Sorry, everybody.
You got it. Thanks.
So just a reminder that the getting us back on track, the priorities for an IPC during this outbreak are really about early identification and isolation of cases. So we really want to make sure that no cases of COVID-19 are undetected in a healthcare facility, because we don't want healthcare facilities to be amplification points during this outbreak. And we also want to make sure that the healthcare facilities are linked in with the public health response for this outbreak. So moving on, just a reminder for everyone that for IPC and healthcare, we think about standard and transmission-based precautions. So our standard precautions are the practices that apply to the care of all patients in all healthcare settings at all times, regardless of pathogen. And the transmission-based precautions are a set of practices in addition to standard precautions that are used for patients with known or suspected infectious agents when you need additional control measures. So for example, our standard precautions as a review are hand hygiene, the use of PPE, respiratory hygiene, cleaning and disinfection of the devices and the environment, in addition to others. And these top 4 that we've bracketed are the elements that are most important for patients with respiratory symptoms. So specifically for COVID-19, some of the main points we try to get across for IPC and healthcare facilities is to make sure that they're adequately ventilated single rooms or ward rooms. PPE is worn according to contact and droplet precautions per WHO recommendations. As possible, we want to use disposable or dedicated patient care equipment like stethoscopes and blood pressure cuffs. And when we say dedicated patient care equipment, we mean that it's only used for patients with COVID-19, and if it needs to be reused, it's cleaned and disinfected between use. We want to avoid transporting COVID-19 patients out of the room that they're in if hospitalized, unless it's medically necessary. And as possible, it's a good idea during outbreaks to cohort or assign healthcare workers to care for patients with COVID-19 and don't have them care for other patients. And then within facilities to have additional administrative controls and policies like restricting the number of visitors that are allowed. So it's a multi-pronged approach for COVID-19 and healthcare facilities. And since this is one of the hot topics for COVID-19, as a reminder per WHO recommendations, the PPE are non-sterile gloves to protect your hands, a face mask, and eye protection, either goggles or face shield. And this, between the mask and the face shield or goggles, is to protect your mucous membranes, and then a gown to protect from any splashes or sprays to the front of your body. And to note that the difference here per WHO recommendations are anytime an aerosol generating procedure is performed. So this includes things like bronchoscopies or any type of initiation of mechanical ventilation is the possibility that aerosols are produced. And this has been in previous literature associated with an increased risk of transmission for the other coronaviruses like SARS-CoV and MERS-CoV. We want to make sure that anything that's aerosol generating is performed in either a negative pressure room or a room with natural ventilation that's exhausting air out of the room. And the difference here in terms of PPE, that in place of the face mask is a particulate respirator, also called an N95 or an FFP2 respirator that is worn. And we want to note here, we made this distinction earlier today, but when we're thinking about infection control for this virus, it's very important to remember that the main mode of transmission, like Manesh said in his presentation, is droplet transmission. As a reminder, an aerosol generating procedure is not the same thing as airborne transmission. This virus is not airborne. It's not like measles or TB. It's spread through droplets, but if you are performing an aerosol generating procedure, there is the risk of aerosols, which can be produced from those procedures. So remember that distinction. I'm going to quickly skip over this slide, but just from CDC and the US perspective, we do have a little bit different PPE recommendations because we took a very cautious and aggressive approach, but those have been modified in the past few weeks as the situations have been evolving and we learn more about this virus. So we like to remind people that PPE is only one part of infection control, and PPE relies on consistent and correct use by healthcare workers, personnel, and that it takes practice and training to make sure that that PPE is worn correctly. And that to make sure when PPE is removed, that it's done so properly which we mean slowly and carefully, and that once you have your PPE on, especially masks and respirators, that you do not touch the front of it, because that's where it's likely to be most contaminated. And lastly, as a quick note, that for environmental cleaning and disinfection, that routine cleaning and disinfection procedures apply. Hospital grade disinfectants that are active against envelope viruses and human coronaviruses work in this situation, and we want to make sure that in these settings, in hospitals and other facilities, that any frequently touched or frequently contaminated surface, like light switches, bed rails, door handles, sinks, or bathrooms or toilets, are cleaned more often than usual. And we also remember that there's a lot that patients can do in healthcare facilities. We can encourage hand hygiene and good respiratory hygiene for patients as well. And this last slide is just the list of resources, which you will have in the slide set, that goes through a lot of the technical guidance that's out there and some additional questions and answers for health workers for your reference. So from there, I will stop sharing my screen and hand it back over.
Thanks so much, Katie. So great presentations, everyone. Thank you for sharing the current information as available from CDC. The last overview presentation that we're going to give now, and then we'll go to some questions that have been posted, is Dr. Brian Bird, who will be talking about the One Health approach. So let me go ahead and pass the baton there.
Hello, everyone. Thank you. Thank you for that introduction, Dr. Smith. I'm Brian Bird. I'm an Associate Director at the One Health Institute, where I work with Drs. Mazet and Dr. from University of California, Davis, on emerging viruses and outbreak responses and many other tasks in our institute. So I'm going to give an overview of One Health coronaviruses in their global context for us. I know we're very much focused on the new coronavirus, SARS coronavirus 2, and the COVID-19 disease and the global pandemic, but I wanted to help everyone put them into a context so that they could understand coronaviruses more broadly. Activities are critical. This intersection of people, the environment, and the animals that we live with are critical in the way that these viruses are transmitted globally. So coronaviruses have been around for quite a long time. They're an extremely diverse group of viruses. If you look on the right of this slide, you can see a stylized family tree of different types of coronaviruses. There are many different clades or groupings, alpha coronaviruses, beta coronaviruses, and the like. And many of these are major agricultural pathogens that we deal with on a daily basis. I myself am a veterinarian and a virologist, also a public health worker. But when we've been thinking about coronaviruses historically, it was really livestock diseases and some diseases of domesticated animals that were our major concerns. Things like porcine gastroenteritis type diseases, massive killers of pigs, chickens, and respiratory complex diseases in cattle. Many other species as well, including even marine mammals like whales and dolphins and the like. When it comes to humans, there have been three major events that have brought coronaviruses to the front of our thinking as potential pandemic threats. Of course, that was the original SARS outbreak in 2003. The emergence of MERS coronavirus, which was a disease that originated in the Middle East region, and now our current global pandemic. But before that, coronaviruses were really quite widespread globally, thought of as causing mild respiratory diseases, typical common cold viruses, as we call it here in the United States. What we know now is that many of these coronaviruses have origins in other wildlife animals. What we know, at least so far, SARS coronavirus 2 cannot infect or cause disease in other domesticated species, and I'll speak to that a bit more in a moment. But when we look at the origins of coronaviruses globally, if you look at some of the work that was done by people in our institute at the USAID supported and funded project called PREDICT that Dr. Mazet has led, one of our most commonly found viruses or virus types were coronaviruses, and these were emerging from bats. Thus far, we don't know yet if SARS coronavirus 2 has a bat origin, but if you look at the family tree on the right, the preponderance of known coronaviruses are from bats. So it's quite this virus is a bat, And these spillovers of coronaviruses from wildlife are really driven by many things. It's not the bat's fault that it happened to have a virus that's caused a global pandemic. It's how we're interacting with the environment and how we have changed land use patterns, and our intensification of our activities around wildlife species has allowed the spillover of this virus into our human population. And just as cartoon schematic, again, the reference is down in the lower right there if you'd like to read more in this particular publication. But we look at the evolution and spillover of coronaviruses as really a multi-species event, whether it's the beta coronaviruses, which are the SARS and the MERS viruses, we're likely to have bad reservoirs and then spill over into humans or other species, or gamma coronaviruses, which are from birds into marine mammals. But when we think about the virus we're interested in today, SARS coronavirus 2, probably has a bat reservoir, but there may be an intermediate host that stands somewhere in between the transmission cycle between the original bat host and us. We know that the types of bats that might be the reservoir species of this new virus are hibernating right now throughout most of Asia. So it is likely that the spillover event occurred into some other animal, but as of yet, we don't know what animal that is. If you look at viruses closely related to SARS coronavirus 2, yes, there is a bat coronavirus that is quite similar, almost 96% similarity at the genomic level. But we know from in vitro studies that this particular virus seems to not be able to enter into human cells very efficiently. So it's not the progenitor virus of this particular outbreak. It's just a closely related virus amongst a constellation of many closely related viruses, including like the pangolin coronavirus, where there are similarities to the current outbreak virus, but it doesn't seem to be a direct ancestral link to CoV-2. And then the to the current outbreak virus, but again, no direct link seems apparent. But when we think about our companion animals, and this is the rounding out the One Health story, we don't know of any known COVID-19 disease in any companion or domesticated animal. There are the 2 dogs that have tested intermittently positive from Hong Kong, and these were companion animals of people who were infected by the virus and developed overt disease. Both dogs were intermittently positive by PCR testing, meaning that the virus genome was there, but they didn't seem to have any disease associated with that. And then later it was found that one of the dogs seroconverted or developed antibodies, suggesting again it was exposed and infected, but again no disease. So it's unclear if they're involved in the shedding of the virus or important in a transmission cycle. One thing we do know, though, is that from experimental studies that were recently published or available in preprints online, experimental infections in rhesus macaques, it does appear that these species of non-human primates are susceptible to infection and disease. The rhesus macaques in particular developed mild disease, but 2 of the animals did have pneumonia signs on postmortem. And then as an important follow-up study, 2 of the monkeys in that trial were infected. They developed mild disease and then recovered. And then the study authors tried to reinfect those animals, and they appeared to be resistant to reinfection, suggesting that hopefully that for human cases, if you extrapolate from the monkey data, it looks like we would also be unlikely to be reinfected from the virus. But it does pose great conservation risks. I know many of you live in countries where there are large numbers of non-human primates, including rhesus macaques or orangutans or other very precious, very endangered wildlife species of non-human primates. many of those non-human primates do have receptor molecules that the virus could use that could cause disease. So it's worth talking across the ministries of agriculture and tourism and land use, whatever you have in your country, to work to get guidelines and recommendations in place to protect these precious animals. In Rwanda and the Democratic Republic of Congo, in Eastern and Central Africa, they suspended tourism in wildlife areas to protect these non-human primates because they are susceptible to being infected from us, perhaps. Right now, there are standing US CDC and WHO recommendations that 6 persons should avoid contact with all household pets, other domesticated animals, or non-human primates. Right? And from our conversations with our AFROHUN colleagues this morning, there were many, many questions on vaccine development. And this is an area I work in somewhat. And I added a few slides here just on vaccines to give people a picture of the overall landscape of the vaccines. And the first thing to say is this is a stunning development, tremendous scientific progress and advances ongoing very, very rapidly. There are multiple agencies and partners working on developing vaccines. The cartoon on the right is just 8 candidates of the 44. There are 44 candidates in development listed by WHO and one of their tracking data. 2 of these vaccines have already made it into human trials, one of those in China and one of those in the United States in the last few days. And I wanted to call special attention to the Coalition for Epidemic Preparedness Innovations, or also known as CEPI. CEPI was funding platform technologies for the next new thing, so-called Disease X. And these platform technologies have now been used already to develop novel vaccines against this new disease. And there were some of the ones listed here on the right. And I just wanted, last 2 slides here, I just wanted to just show, you know, for those of you that work in vaccine development, you know that the process can be extremely long, extremely excruciating in the amount of work that goes into developing vaccines. And on the top of this slide is just sort of a typical pipeline. You can read the article there, and the link has a nice thing about what it takes to get a vaccine developed. And often this is on timescales of decades. You know, most people spend half or 3/4 of their career working on a single vaccine to get it through to human trials and eventually, hopefully, on a shelf in a pharmacy where it could be of use. When you look at the SARS coronavirus 2 vaccine pipeline, it is stunning. Just in a matter of days, we have gone from the first reports of atypical pneumonia at the end of last year, or late December, the first isolation of the virus just a week later, to just a few days later, the complete genomic information of that virus. You know, and then as you go forward out to March 16th, so just a few days ago now, the first human volunteers were vaccinated with vaccine candidates. So if you look at the top pipeline, that's decades, that's a career's worth of work. And now we're into days. And if you do the calculation, it's 64 days, which is just a tiny sliver of that top green bar. So it really shows the commitment, I think, of our scientific colleagues across our networks, across Asia, Europe, and the United States, and elsewhere, to really appreciate how important this disease is and how significant this global pandemic is. And with that, my last slide is just a link of coronavirus resources where I drew this information from, and some of the links are embedded in the slide. So please check these links. There's a lot of interesting information there, and I'll yield back to the chairwoman for the balance of my time. Thank you.
Okay, thank you so much. Okay, I think we have our sound sorted here. So really excellent presentations to get us started. Also a lot of really excellent questions coming through in the chat box. So what I would suggest we do is go ahead and take a few questions now. And then I would like to be able to have some informal comments shared by some of the folks who were there in the region. So I know some of our OHUNs that are part of SEAOHUN are tuned in now, and I would like to invite a representative from each of those to share a few comments on the situation in your country if you would like to. So perhaps think about what that might be. And we also have Philippe here from FAO who will be able to share some context for what's going on. But I think first we should go ahead and take a few questions and go from there. So the first question, I think I'm going to ask Katie to give us a little more insight into the idea of masks. We've had a lot of questions come in about what type of masks are good enough. Can we re-sterilize or do something different if they're in short supply? Any additional comments, Katie, you'd like to share when we think through the perfect case scenario as compared to the reality of having limited resources in some situations?
Yeah, this is a great question. So we do get a lot of questions, especially in the past few days here in the US, about PPE shortages and what to do, especially with face masks and respirators. So well, I'll say a bit and then also point everyone and to the CDC website. I know that WHO will have some text and guidance forthcoming on this, but on the CDC website, you can find strategies for optimizing PPE use. And so this talks about optimizing PPE use in a conventional strategy and then a crisis strategy, which I think a lot of countries are in. So I encourage everyone to read through those for both how to extend the life of masks and respirators, and also thinking about extended use, reuse. And there is some forthcoming information about reprocessing some of those items and what that means in terms of safety and reuse. And so there's a lot of new information coming to this, and I think we're all learning together. But for now, can point you to some of that info on the CDC website to read. And then I think as we reconvene, we'll be learning more about what people are using and get some actual data on it.
Thanks for that, Katie. Next, I'd like to go back to Chris and invite her to make any follow-up comments related to some of the additional testing questions that have been coming through. I don't think we need to go into specific sensitivity or specificity values here. We can compile that with what's known or not known as the follow-on, but I know there have been a lot of questions coming through related to testing approaches and even related to whether BSL-3 or BSL-2 facilities could be used for testing in some situations. So Chris, anything else you'd like to share?
Yes. First, I'll start with the last part that you asked. And BSL-3 is not necessary. If you're using PPE and appropriate best practices for biosafety, BSL-2 laboratories are perfectly adequate. But as I had shown in my slide, you should be working in the BSC, and that wall of air does protect you. And of course, wearing appropriate personal protective equipment, goggles are also suggested. WHO, and I linked this in my talk, WHO has actually a very nice overview of biosafety practices for working with SARS-CoV-2. And so that is linked in the talk. Now I'll get to the different assays. There are so many questions about point of care tests. Most of these lateral flow assays or dipstick tests are antibody tests, and these are not as useful for measuring initial infection at this time. They have not been thoroughly evaluated. And it was posed to me the question, what were they using in Korea? And they were using a lot of different tests, and they may well have been using a test like this, but I do want to clarify something, that this drive-through testing that is referred to quite often is not actually testing, it's sampling, taking, nasal and oral pharyngeal swabs, and then it's tested, and that results sent to the doctor. And so it's kind of a misconception that the testing is actually drive-through, because it's not. But the tests that we can recommend at CDC are tests that WHO is using, and which is primarily the German test, which is an real-time RT-PCR. And then also these new tests that I mentioned, and you can find these tests on the FDA website. If you Google FDA EUA coronavirus, you will get a page that has a table with all these different tests in it, including the Gene Expert. And we can recommend those tests. there are more tests out there than have been evaluated by WHO or CDC, so I can't answer all of your questions. But thank you for asking, and hopefully we'll have that answer in the near future. Over.
Thanks very much, Chris. Bruce, I'd like to go over to you in case you had a favorite question or two you wanted to pull out, and then I think we should get some of our regional context comments from participants.
Great. Thanks, Bautrina. You know, I just saw a question from Todd Pollock in Vietnam, former colleague of mine, who was asking, do you recommend to quarantine every health worker with potential contact to a case, or as suggested by a recent article by Atul Gawande, where the risk of transmission is low unless there's sustained contact? So just wondering, as more and more healthcare workers, and a colleague in Indonesia brought this up in her question, what's the best strategy for protecting healthcare workers and how to manage when they've been exposed? And I don't know if Manesh, you would be the best person, or who might give that a try.
So I can start, in Manesh, if you want to add in anything additionally.
Okay, thanks, Katie.
Yeah, so I think there are a number of strategies for thinking about risk exposure for healthcare workers, and then the subsequent so risk assessment, and then decisions about what that means for healthcare workers and monitoring. So we've seen a number of different strategies in use. In some instances where it's feasible to do, contact investigations and risk exposures for healthcare workers, we do recommend that as a first step to be able to classify if healthcare workers have high risk exposures. For example, doing an aerosol generating procedure without a respirator on might be considered a high risk exposure. To kind of risk stratify healthcare workers into high risk exposures or low risk exposures, and depending on the framework you're looking at, might also be medium risk exposures. And then based on that classification, making recommendations for what that means in terms of next steps for healthcare workers. Here in the US, it's evolved a lot. And in the beginning, we were able to say that healthcare workers who are exposed should be furloughed, so not work for 14 days and find alternative things to do that are office-based. But as we saw, for instance, in Seattle here in the US, when we had upwards of 700 healthcare workers exposed, it's no longer feasible to do individual healthcare worker risk assessments, and instead they had to do blanket recommendations for healthcare workers. And so in that context, they used the approach that all healthcare workers who are exposed go under active monitoring. So that means they're checking in with someone from the facility or the health department once or twice a day. And if they do become symptomatic, they're not working. And there are various strategies in between those that can be used. So it's dependent on the context. But there is guidance from WHO and from CDC that can be looked at for healthcare worker risk assessment and monitoring, and what to do for follow-up in terms of quarantine and returning to work. Over.
Great, thanks, Katie. I have one more question. I think this is for Manesh on reinfection, and what do we know about reinfection possibilities? And in terms of thinking of herd immunity, what evidence do we have that we can expect herd immunity?
Thanks. Bruce, I know you threw it to me, but actually what Brian presented, I think may be the best information that we have now on reinfection. And if Brian can comment, if there's more than what he presented, I'll defer.
Great, Brian, any comments on that?
Yeah, sure. So I think that non-human primate data is our best data thus far. I know there have been reports of people that have been tested, have been symptomatic, and then have been test negative and then test positive again. I think we have to be very cautious in interpreting that as a reinfection, like a de novo, truly repeat infection, because what we know with molecular diagnostic is that the sensitivity of these assays is so extreme, super sensitive. And that what we see, I've done a lot of work and other infectious diseases using molecular testing and outbreaks. And what you see is a long tail of intermittent positivity. And that's because there's still pieces of the viral genome, not infectious, people are not infectious in any way, but still hanging around. And occasionally those tests will pick that up and they'll appear positive again as a low positive. So I think the monkey data, though, really suggests that, at least in that animal model species, so rhesus macaque, those animals developed an immune response. It could be antibodies, it could be T-cell responses, and we'll figure that out with more time. But those animals were resistant to reinfection. And so far, that's our strongest data, showing or suggesting that vaccines will work.
Thanks, Brian. Trina, back to you.
Okay. So I think that we've got the start on some really nice answers, and there's some common themes coming out in the questions, which is great. We do want to take the next little while to invite comments from some of our regional partners in Southeast Asia. So I know that we have representation from many different countries here, and I think I would like to invite any of the folks from our OHUNs and SEAOHUN, so MAYAHUN, TOHUN, INDOHUN, BOHUN. If you'd like to have a representative, just use the raise your hand icon to indicate that you'd like to share some comments from what's going on in your country or any specific ideas and questions you have. Go ahead and use the raise your hand icon, which is at the bottom of the participant box, to let us know that you're ready, and we can go to you. While you're thinking about that and getting organized for any comments you'd like to share, I will go ahead and have Philippe give us his quick comments on the region from the FAO perspective and what we do or don't know there. Philippe, would you like to start us out? And then others can be able to raise their hands if they'd like to share comments from their country or their regional situation while we're all here together.
Okay, Trina, no problem. Can you hear me all right?
Yep.
So for those who don't know me, I am Philip Klaas. I'm the regional laboratory coordinator working for the FAO Food and Agriculture Organization Asia Pacific office. And the Animal Health Service falls under that. So we do a lot of work on zoonotic diseases, avian influenza, etc. So when early January, we started to hear some rumors about the disease. It wasn't confirmed it was a coronavirus yet at that time. We already had our laboratory networks looking, and we had colleagues like within EcoHealth Alliance, within Hong Kong University, etc., to inform us about the infection. So pretty early on, we were aware of, before it was officially announced that it was a novel coronavirus. So on the animal side, what we did in terms of preparedness is to make sure that our laboratories have the testing capacity, although we don't recommend any surveillance now as to not scare or overreact on livestock or wildlife animals. At least we want to be prepared in case something comes up. So we had corona experts join us. We came up with SOP, so mainly the German protocol from Drosten's lab, what type of samples that can be used in terms of nasal or rectal samples, and biosafety guidelines, so BSL-2 plus for molecular work, BSL-3 for propagation. So all these things we have ready on the animal side. Also in terms of epidemiology, we have a whole network of trained epidemiologists in countries. So on that side, we try to be proactive to make sure that we are ready on the animal sector. Currently, of course, it's mainly a human health crisis, but later on there may be some more questions about animal reservoir or things we have seen during H1N1 where there was reverse zoonosis from flu going back into pigs. So all this type of questions we want to be ready. So at the moment we sit a little bit back. It's mainly the public health sector taking the lead, but we want to make sure that at least the animal sector is prepared. In terms of communications, that's the last part I want to make. There were some there was the 2 dogs in Hong Kong, but also WHO put out some recommendations about please avoid unprotected contact with animals, etc. And that actually scared off some people, and we had reports of people throwing off their cats and dogs off balconies in certain countries. So we reached out to WHO HQ, and they actually took our advice, and they actually took off all their recommendations currently on animals on their website. So you'll see WHO actually took them off. It's not that we don't think about it, but we're actually thinking more about the animal welfare in this certain case, and make sure that people don't revert to cruelty to animals at this stage. So I'll stop here and take any questions for FAO if there's any. Over.
Thanks very much, Philip. So I think we should be able to take questions through the chat box. That would be great as we go forward. And then I think we should hear from some of our countries if they would like to share comments. So I'll go ahead and rotate through and see whether we have a representative who would like to share from each, and then we can open it up more broadly. So as I look through the list here, I see we have Latifa from SEAOHUN. Latifa, would you like to share anything specific to the Malaysia situation while we have the floor with our community of practice and One Health, as well as experts from around the world?
Hi everyone, this is Latifa from SEAOHUN.
We hear you. Go ahead.
Okay, so we are on our 6th day of movement control order. As you probably know, we are on the 2nd phase of outbreak. I'm still not authorized to comment too much on what has been done at the country level in terms of our disease control, but this is just from my perspective as an academician and as a general population and community. There's a lot more awareness among people. I can see from my family members in terms of what they should or should not be doing. Initially, a lot of people are not very wary and were taking things a little bit for granted when the government was trying to make people, get people to do social distancing and just to reduce congregation. But now there's a lot more awareness and people are abiding, I think, from what I see, by what the government, and there's a lot of political support in terms of supporting the Ministry of Health with what they want to achieve. Everything is done, I think, even from the initial part, a lot of it is an interagency kind of collaboration. And even our king actually got onto the social media and also on the national news to actually plead to everyone to just stay at home at least until end of the month, until we see how things are getting on before the government actually will decide whether the movement control order will end or will have to be continued until the middle of April, or perhaps even until the end of April. So for now, even with on the 6th day of movement control, the number of cases is still, yesterday was actually the largest, I think, that I've seen in terms of new cases reported. We have not seen in terms of decline of cases yet, but hopefully, as we go along with the movement control, we'll see less and less cases, number of cases in the country. The Ministry of Health, individuals, the frontliners, they are trying their best and they are doing a fantastic job. And I really truly appreciate whatever that they are trying to do. They really are very hardworking. I think that's it from Malaysia.
Thanks so much, Latifa. I'd like to offer perhaps from Vietnam. Do we have Dr. Phuc still with us? Perhaps any comments you'd like to share just informally on the situation or ideas that you have?
Hi, everyone. Can you hear me?
Yes, you sound good.
Well, thank you very much. So I'm Phuc from Vietnam One Health University Network. So I try to update a little bit our situation of COVID-19 in Vietnam. So now in Vietnam, totally it's 123 positive cases, but it's a total recovering 17 cases, but 4 cases serious, severe cases still in the hospital, and they use ECMO therapy to treatment for them. Until today, is a total number of suspected cases include more than 7,000, nearly 8,000 people, and number of suspected cases under surveillance and isolation is a quarantine is 645. Almost of cases contact and they entry from the overseas. They are back from the other country, and almost it's a positive case in hospital with 2 nurses. It's a back my hospital and 1 medical doctor. It's a positive case yesterday. It's a long contact exposed. It's a patient in the hospital, but we see that maybe it's like person to person of cross contamination in the hospital or direct from the patient. And number of positive negative sample they were tested more than 17,000 sample, and you see that which the government they are very high in the control, and they now all the people let come to the meeting and gathering meeting or conference, but stay at home and they can work that through it's online. Of course, they inform to the hand washing and use the disinfectant and wear mask. Even when they go out, need to wear the mask. Even wear the mask during in the office. If it comes to the office, you need to wear the mask all the time. So that I think that in the government is well control, and they use the network until the community. So it's really they are monitoring and control the person. So I think that at the moment it could be well in Vietnam, but we will not see how it is the future. And for us, it's an issue. The people they are trying to look in some kind of medicine like chloroquine for prevention. Even the people in the negative cases, that is the big issue in Vietnam because the pharmacy people they can come to the pharmacy to buy the chloroquine very easily, and the price increasing because they believe that it can protect and prevent it, COVID-19. So what is the issue? We cannot control at the moment. Okay, over from my side. Thanks.
Thanks so much, Dr. Phuc. Okay, do we have any representatives from other SEAOHUN countries who would like to share additional comments beyond what we've initially heard here? If so, please use the raise your hand icon and we can go ahead and take a few minutes. Otherwise, we will go to a few of the questions that have been shared through the chat box. And I think we're actually getting some nice answers coming through on the chat box as well. So thanks to all of you who are contributing that as we go along. Okay, I don't see any more hands raised with the icon from Indohun or Tohun or Laohun. So we can go ahead and take a few more questions for now, but if that would change, then we certainly can go back to you.
Trina, does Dr. Sudarat want to make any comments from our DMA?
That would be lovely. Sudarat, I actually had chatted with you, but I know there's so many things coming through the chat. Any comments you would like to add on at this point, or shall we keep going?
Can you hear me well?
Yes, we hear you.
So I think from Thai side, right now we are facing a lot of problem with the N95 and PPE shortage. But this is, I understand, it's the global shortage of PPE, and right now we are facing of a diagnostic reagent also. And this is not only for Thailand, right? Because it's more increasing case, and people around the country, the world, try to do their contact tracing, and we rely on the available of the diagnostic reagent. That is a very, very global concern right now. We got the request from MOPH in Thailand for the PPE and also the reagent. So that is something is not easy to sort out nowadays at the regional and at global level. And for me, I think for Thailand situation, we are in the what we call epidemic curve. It seems like we start to see more cases, and because the issue of non-asymptomatic or mild cases, so people did not recognize that they got infected, and then it's a big cluster going around in the country, and the government try very hard. We don't call it a lockdown, but right now we coming so close to that situation, especially in Bangkok. And and the government requests community engagement and participation on social responsibility, social distancing, more telework. Even USAID, RDMA right now, we going to have 100% complete telework, and not allow for even attend the meeting in person. So right now we use all virtual meeting, and even attending the meeting with the government, we are not allowed. So we can support the government to virtual by video conference or telecon, and helping them review the the article or even document virtually. So that what the government put a lot of their effort to flatten the epidemic curve. So, and I think we will hear more and more on the control measure, mitigation measure, and we become more strict, because and another one that I think because of there is the information yesterday circulating around regarding aerosol generating procedure, so we have to answer to many groups, because people become more panic, but actually this is more procedure at the hospital, is not for the general public, but it's a lot of missing. And the Thai media, when they translate this, they just focus on the aerosol, the airborne infection, so make people more scary. But I think we have to provide the right information and calm down people. And another one, people, I think the group asking for drive-through. In Thailand, we also, I think the private hospital provide, like 2 hospitals, provide those drive-through service. But this is just for sample collection, okay? It's not rapid test or anything. They have to send it to the recommended laboratory, and then it go to the process. I think we're still using real-time PCR like a standard procedure, but this just allow, for service, drive to sample collect any rapid test or anything that we can get the result within 30 minutes or anything. And another one I would like to ask you there, I would like to get more update on there, if there is a available commercial serological test, reliable test that we can use it right now, with more specific and sensitive assay, in additional to use it with the nucleic acid detection.
Thanks.
So that's from my guys. Yeah.
Yes, thank you, Siddharth. That's very helpful and wonderful context and really insightful questions. Chris, do you want to, Chris Shale, do you want to provide any comments with regard to the availability of serological tests in the way that Siddharth is asking, or whether that's still to come?
There are plenty of serological tests available on the market, and FIND, the Foundation for Innovative New Diagnostics, something like that. I did include the web link on my slides, and WHO is working with FIND to evaluate these tests, but I don't expect the results to come out anytime soon. I can't recommend an antibody test. I encourage you to evaluate it on your own if you have the bandwidth to do that. I think, you know, there's no harm in using an antibody test alongside of a molecular test, and the molecular test should be used for diagnosis, but it may be very informative to do both at the same time, and then you might have a better understanding of how those molecular tests work. So I'm not going to tell you don't use it. I can tell you that we haven't evaluated and cannot recommend it. And so there are everything from dipstick assays to ELISAs on the FIND website, and yeah, they're out there. And so I think it's really up to you if you want to try to use that, but we encourage you to use a molecular test for diagnosis.
Thank you. And we will have the regional public health laboratory network, the video conference call on the 30th. And I think we will hear more the update, because the next topic, that the focus topic is going to be the serological test. And I think they invite the Singapore who start using it, and including Duke University to join the telecon on the March 30th. Thank you.
Thank you. And I would be interested in hearing more about this, because we're interested in it. We just haven't evaluated it yet. Thank you.
Great. Philip, did you have something to add based on the comments that have come in just now?
Yeah, basically to add on to what Sudarat is saying in terms of the animal side and the shortages of molecular diagnosis, etc. So I think this is one of the spin-off effects that we also start to see, not for SARS-CoV-2, but things like African swine fever or avian influenza, where we're really scared that these efforts are all going to be severely hampered by shortage either of diagnostics. So far, at FAO site, we had enough stock and we could provide people with molecular reagents to do their avian influenza surveillance. We hope that continues. But what we already see in certain countries currently dealing with H5 and 6 outbreaks, the people were contacting us because they simply had shortage of Tyvax and N95s, etc., to deal with the culling. So you see that we start to see these spin-off effects of COVID-19 onto other diseases such as bird flu and African swine fever in terms of logistics. And then I saw a quick question somewhere on migratory birds and coronavirus. I think most birds have gamma, maybe delta coronaviruses, but not beta, but there's more virology experts around here. So I don't think they're the main risk factor for spreading coronavirus, in my opinion. That's it. Over.
Thanks for that. We are almost at our time, so I'm going to go briefly to Jonna and Pat for any last comments that they would like to share with the group. And Bruce will also, I think, have a bit of a closing to just provide to the group for the attestation. So Jonna, first to you, and then to Pat for any final comments.
Thanks. As we talked about when we started today, I think it's really critical to have these kinds of networks where we're supporting each other. We have places to go. We find out how to stay connected past these initial activities and information exchanges. And I'm just thrilled to be partnering with all of you, but especially our SEAOHUN. And I'll turn it back over to Dr. Pat in a second. I do think for all of us, we need to consider especially the equity situations and economic impacts and how that balances with mitigation measures that are so critical at this time. All of the countries represented here today were kind of in different stages of our local epidemics as part of the overriding pandemic, and we certainly need to practice as good of hygiene and staying home and doing all that we can to halt and slow this epidemic. But it is going to be quite some time until we have a vaccine widely available. And we are going to need to be thinking about how we really address the public's concerns and do the best thing for all of our healths. And that includes our economic health, so that we can reduce anxiety and have nutritional security and all of those things. So I look forward to working with all of you and supporting you as we can. But together, I do think that we can really get good information out into the public sector and support each other and support science. So Pat, over to you.
So actually, don't have additional but just draw off today, and we look forward to staying connecting with you and working together, and hope that everyone stay safe and healthy. So over to Bruce, I think.
Great, thanks everybody. I just want to extend additional thanks to all the participants from across Southeast Asia and to our speakers from across the United States, and for coming together. I hope this is the first of what will be many dialogues, and now particularly when it's difficult for us to travel in person. Hopefully we can use this type of platform to share experiences, best practices, and learn from each other as we're all working through this pandemic over the next probably many months. So as I end, I'm going to share my screen one last time. For those who use the PDA participant app, this final QR code, ideally you'll scan that, and that will complete your attestation, and it should make sure that you get all the PowerPoint presentations loaded onto your mobile device. Also want to call your attention to the continuing professional development links that have been in the chat. They should also be in the announcement. We really value your feedback, and you will get instant continuing professional development credit and a certificate as soon as you take 2 to 3 minutes to complete the survey. It's how we improve the quality of what we're doing, and we'll use the information to future events similar to this. So thank you again, and I'll bring that down and just say goodbye to everyone. Hope everyone stays safe and have a very good week, and hopefully we'll meet again soon. I'll then put the slide back up so that people who didn't have a chance to scan it can do that. But for the moment, thank you, and have a great week.
Thank you so much, everybody, for speaking, especially, and for coming on.